Being here this afternoon. This is the Chest Essentials course. My name is Paige McAdams, and I'm going to be discussing for the next 20 minutes some aspects of sarcoidosis. I'm going to review some of the more common radiologic aspects of sarcoidosis, particularly in relationship to CT scans. Hopefully we'll have a little time to review a few less well-known, recognized, or discussed aspects of sarcoid, and to do so in a case-based format. By way of introduction, as you know, sarcoid is a disorder of unknown etiology or etiologies that is characterized by non-necrotizing granulomatous inflammation, as is shown on this H&E slide. While sarcoid can involve any organ system, the thorax is involved in over 90% of the cases, and that will be the focus of my discussion. Involvement in the thorax can result in severe fibrosis in anywhere from 20 to 30% of affected individuals. This first patient is a 32-year-old man who presented with dyspnea and underwent high-resolution CT. And you can first appreciate on the CT a micronodular pattern. There are multiple, very tiny lung nodules, all less than 5 millimeters in diameter. Now, when you identify a micronodular lung pattern on CT, it's important to try to characterize the location of the nodules for differential diagnosis purposes. So if we look at the relationship of the nodules to the secondary pulmonary lobule, we see first and foremost that we have nodules which are clustering along bronchovascular bundles. And out here peripherally, we'll see that they cut in cross-section would appear as centrilobular nodules. But the other characteristic feature here is the fact that there are nodules which are aligning themselves directly along the pleural surfaces out there peripherally, as you can see here, and along the fissural pleural surfaces as well. And when you see nodules that are touching the pleura like that, that is what denotes this micronodular pattern as a perilymphatic pattern. Now, there is a broad differential diagnosis for perilymphatic nodules, but certainly in this country, and I think in many others, the most common cause for perilymphatic nodules will be sarcoid. This patient underwent a transbronchial lung biopsy which showed non-caseating granulomas, confirming a diagnosis of sarcoidosis. Now, let's talk a little bit about common CT findings in sarcoid. Nodules are seen at presentation in up to 100% of affected individuals. The most common pattern for nodules is that which I've just shown you, the perilymphatic pattern. Again, characterized by nodules less than 5 millimeters in diameter, which are peribronchovascular in distribution, cut in cross-section, may appear as centrilobular nodules, but have that very characteristic alignment along the posterior pleural surfaces, as you can see here, and along visceral pleura. But sarcoid is such a common disease that other patterns are not all that uncommon. Sometimes you'll see a true random or miliary pattern of micronodularity. Sometimes the centrilobular nodules will be more of ground glass attenuation and appear as the nodules that you sometimes see in patients with hypersensitivity pneumonitis. You may see larger nodules greater than 5 millimeters in diameter, sometimes mass-like in appearance. Here's another patient with path-proven sarcoidosis. It's very difficult on the individual axial images here to appreciate all these tiny 1 to 2 millimeter nodules that are diffuse in distribution. We don't really see a perilymphatics pattern so much. As you may know, maximum intensity projection images are very helpful for depicting a fine nodular pattern, as they were in this case, in a patient with more of an even or diffuse distribution pattern that looks like a miliary pattern. There's another patient with path-proven sarcoid. Some of the nodules appear to be perilymphatic in distribution, as you can see here. Some are soft tissue attenuation, but in other areas you have more centrilobular areas of ground glass attenuation, simulating the appearance, for example, of hypersensitivity pneumonitis, but this is another patient with sarcoid. Yet another patient with nodular sarcoid. In this case, many of these nodules are larger than 5 millimeters. Notice that many of them are clustered along bronchovascular bundles. In some areas, you have a bit of a perilymphatic pattern, but the majority of nodules are either peripheral in distribution or along bronchovascular bundles. Obviously, in a case like this, your differential diagnosis would be more broad. You might think about infection, for example, metastatic disease, but consider sarcoid in your differential. The eagle-eyed in the crowd will notice that there is also adenopathy in the paratracheal, subcoronal region in both hyla. Again, findings which would suggest the correct diagnosis of sarcoid. Now, sometimes when you have these nodular opacities, you will see these small little nodules around the lesion at the edge of these opacities, and this has been termed the sarcoid galaxy sign, and you can see why. Here's a galaxy with the central conglomeration of nodules and these little micronodular pattern at its periphery. Again, it's a non-specific finding, but in the appropriate clinical setting, you want to think about sarcoid and the differential. Another patient with sarcoid, in this case we have larger areas of homogeneous opacity, peripherally distributed, air bronchogram sign. We might call this pattern an alveolar sarcoidosis pattern. I will point out that the margins of some of these lesions, we see that micronodular pattern as well. Now, alveolar sarcoidosis usually occurs by virtue of confluence of micronodules and interstitial granulomas, which efface air spaces and can result in an air bronchogram sign. But in pathology, occasionally true airspace involvement is seen, sometimes characterized by an organizing pneumonia pattern. One of the tip-offs, as in the case I just showed you, is the micronodular pattern at the edges that you may see of these lesions, the so-called galaxy sign. Now, ground glass opacities are not commonly, I guess, in our thoughts associated with sarcoid, but they're not terribly uncommon in patients with extensive sarcoid. It's just that they're associated with sarcoid, but they're not terribly uncommon in patients with extensive sarcoid. It's just that they are rarely the only finding. They usually occur in the setting of other more typical findings. And they can occur because of a profusion of tiny submillimeter nodules that are below the resolution of the CT scanner to depict as individual nodules, or in the setting of fibrotic sarcoid by very fine microscopic fibrosis. Here's a patient with very extensive sarcoidosis. In some areas it has a characteristic perilymphatic nodular pattern. In other areas it appears more centrolobular. But notice that more centrally we have some ground glass attenuation opacities, which in this case no doubt represents a profusion of tiny nodules at the microscopic level. It's a patient with more advanced sarcoidosis. This is fibrotic sarcoid. You can see these irregular linear opacities. Parabronchovascular distribution. We'll talk a little bit more about fibrotic sarcoid here in just a second. But notice the ground glass attenuation opacities here, which if I was to cut this lung in cross-section, we would see is likely due to microscopic fibrosis. So ground glass can be seen in patients with sarcoid, but it's rarely the only finding, actually quite rare for that to occur. Now, our next patient is a 56-year-old person with severe dyspnea, and you can see that this patient has very advanced fibrosis. They're thickened inter- and intralobular septa, traction bronchiectasis. We see the beginning of some subpleural cyst, perhaps even a little bit of honeycombing. Notice the upper lobe distribution here, which is typical of sarcoid, and the calcified nodes, which we often see in advanced fibrotic sarcoid. So fibrosis, as I mentioned, may be seen in between 20 and 30% of individuals overall. It is usually mid to upper lobe distribution. It is characterized by reticular or irregular linear opacities, traction bronchiectasis, occasionally subpleural honeycombing. You may also see progressive massive fibrosis with conglomerate masses, and in that setting you may also see development of large bullae or fibrocystic changes in the upper lobes of lung. Now here's a patient with sarcoid with fibrosis. In this case it's characterized primarily by linear opacities. Notice that they are parabronchovascular in distribution. The upper lobes are affected more than the lower lobes, so that pattern, the parabronchovascular distribution, the appearance is entirely in keeping with fibrotic sarcoidosis. Here's a case I showed you just a minute ago, cut in coronal section, much more advanced fibrosis. Can clearly see the traction bronchiectasis and bronchialectasis, subpleural cyst formation, perhaps honeycombing, perhaps some parasecretorial emphysema. Notice again the upper lobe distribution and the extensive calcified lymphadenopathy. Now, as I mentioned, true honeycombing is occasionally seen in patients with sarcoid. Excuse me. So this is a patient with advanced fibrotic sarcoid. And you can see that they have extensive honeycomb cyst formation. If I took this lung and put it in the lung base, reverse the distribution, we'd say, well, this patient likely has IPF. However, this is upper lobe disease, and you can see we're getting a lesser amount of disease as we go toward the lung bases. So upper lobe honeycombing, we want to think about sarcoid in our differential diagnosis. Now, patients with fibrotic sarcoidosis may develop conglomerate masses, which are very similar to those seen in patients with silicosis and coworkers pneumoconioses. Some important differentiating features that can be helpful on occasion. The lesions or conglomerate masses in patients with sarcoid are more distinctly perihilar in distribution than those of pneumoconiosis, and you may see our bronchogram signs within them. So here's a patient with fibrotic sarcoid. Upper lobes affected more than the lower lobes, coalescing into these large areas of mass-like opacity. Notice that they are perihilar in distribution, and notice the bronchogram signs, which are typical. And you can compare and contrast that to a patient with coworkers pneumoconiosis, where the masses are more well circumscribed. They're a little bit more distant from the hyla, and we don't typically see our bronchogram signs in the conglomerate masses of coworkers or silicosis. However, on a case-by-case basis, it's often difficult to differentiate sarcoid from pneumoconiosis in the presence of conglomerate masses. Now, bullae or cysts, large bullae or cysts, are not uncommon in patients with advanced sarcoid. They're usually in the subpleural regions of the upper lobes. They may be associated with development of conglomerate fibrosis. They are an important risk factor for development of mycotomas. Mycotomas in patients with sarcoid are frequently multiple. They have a propensity to bleed and can cause significant morbidity and mortality. So here's a patient with advanced fibrotic sarcoid, very typical perihilar fibrosis pattern, a large bulla in the right upper lobe, several bulla in the left upper lobe with intercavitary masses, seen to better advantage here on the CT scan, where we see two mycotomata here with a little bit of calcification within them. Next patient is a 58-year-old woman with a very long history of sarcoidosis. I think it went back 20 years or so. She developed increasingly severe dyspnea and marked decreased exercise tolerance, and she had this chest radiograph. You can see that her pericardial silhouette is enlarged. She has a small right pleural effusion, which is not all that common in patients with sarcoid, but otherwise has a typical upper lobe pattern of fibrosis we see in patients with advanced sarcoid. Now, on our CT scan, again, we see these clustered areas of fibrosis paralleling the bronchovascular bundles. Notice the traction bronchiectasis, a huge bulla developing here, but on the whole, her lung disease is not all that severe. Notice, however, on the mediastinal window that her pulmonary artery is quite large. I think the diameter exceeded 4 centimeters, and most importantly, the ratio of the diameter of her main pulmonary artery to the ascending aortic diameter was 1.6, so much greater than 1.0. And those, of course, are findings which should suggest the possibility of pulmonary hypertension. She was taken a right heart cath. It showed these numbers, which I won't belabor the point, but are consistent with a diagnosis of pulmonary hypertension. So I just wanted to talk for a minute about sarcoidosis and pulmonary hypertension. All right, the overall incidence is variable. So if you look at all sarcoid patients, somewhere between 5 and 20% will develop pulmonary hypertension. If you look at patients with sarcoid and severe symptomatology, as in our index case, the incidence of pulmonary hypertension is substantially higher. And then if you look at sarcoid patients who are being referred for lung transplantation, almost all of them will have some degree of pulmonary hypertension. The severity of pulmonary hypertension generally correlates with the severity of lung disease, although a minority of patients with pulmonary hypertension will have relatively minimal lung disease. The importance of pulmonary hypertension in the setting of sarcoid is that it's an important independent predictor of mortality. In fact, if you look at a hazard ratio for death in sarcoid between those that have pulmonary hypertension and those that do not, the hazard ratio exceeds 10. Walsh and colleagues published a very interesting article in the last 2 years where they looked at patients with advanced sarcoid using both a test and validation cohort, and they identified two imaging predictors and one clinical predictor of poor versus good outcome in patients with sarcoid. The first was a composite physiologic index, but the two imaging descriptors were the extent of fibrosis on high-resolution CT with a cut point of 20% and an increased ratio of the main pulmonary artery diameter to aortic diameter of greater than 1, which is a surrogate marker for pulmonary hypertension. And if you look at the data for this study, all three of these things proved to be powerful and independent predictors of poor outcome in patients with sarcoidosis. So if I look at this patient, they have fibrosis, which is clearly more than 20% of the whole lung. They also have an elevated pulmonary artery to ascending aortic diameter ratio. Those are two independent predictors of poor prognosis, and it's something that you should look for and perhaps comment on in your reports in patients with known or suspected sarcoidosis. Next patient is a 42-year-old woman who had hepatitis C. Actually, she had that for a number of years. She developed a cough and dyspnea. She underwent high-resolution CT. You can see that she has a classic micronodular pattern. Notice that there are nodules along the fissures here. In some areas it looks relatively diffuse, but the fissural involvement denotes these as perilymphatic nodules. So we're thinking here about the possibility of sarcoid. She underwent a lung biopsy, and you can see very nicely the non-caseating granulomata in the interstitium and arrayed along the interlobular septa, features which were diagnostic of sarcoidosis. Now, a little bit of additional history here. It turned out that prior to the onset of symptoms, she had recently been started on therapy for hepatitis C, consisting of interferon alpha and ribavirin therapy. So this is in fact a case of a sarcoid-like or sarcoidosis secondary to drug therapy. So if you look back in the literature, it's been described for a long period of time, some patients on drugs developing a sarcoid or sarcoid-like or granulomatous interstitial lung disease related to the therapy. It turns out the drugs that are most commonly implicated are the alpha beta interferons, which are used for treating hepatitis C, as in this particular case. But something to remember more recently, there's a description of drug-induced sarcoid in the setting of patients receiving anti-TNF alpha inhibitors. These are, of course, drugs that are very widely used now for a variety of non-neoplastic inflammatory condition, and there are some case reports and small series out there of these patients developing a sarcoid-like reaction to those drugs. So it's just something to keep in mind. Now, in terms of imaging, although reports are relatively limited, it seems that drug-induced sarcoid resembles idiopathic sarcoid for the most part. One article suggested that you might see a little bit more ground glass opacity than you would see in a patient with idiopathic sarcoidosis. But most importantly, it's important to think about it because disease clinically and radiologically will usually resolve with cessation of therapy, and usually relatively quickly. Okay, so let's sum up. Perilymphatic nodules are the most common CT manifestation by far of sarcoidosis. Fibrosis, when it occurs, is typically upper lobe in distribution, characterized by reticular opacities, traction bronchiectasis, occasionally honeycombing. You may see conglomerate masses which simulate those seen in the pneumoconioses. These patients may also develop large bullae or cysts in the upper lobe, and when they do, you have to be attuned to the fact that they may develop mycotomas within them, because that can be a very important cause of morbidity and mortality. Poor prognostic features in patients with fibrotic sarcoid, fibrosis that involves more than 20% of the whole lung, or an elevated main pulmonary artery to a sitting aortic diameter that exceeds 1.0, as that is a marker for pulmonary hypertension. And finally, sarcoid-like reactions can be seen in the setting of a variety of drug therapies, typically the alpha and beta interferons, as well as the TNF-alpha agents. And although I didn't have time to talk about it, can be also seen in the setting of a response to known neoplasm. So with that, I thank you very much for your attention. And now it's my great pleasure to welcome to the podium Dr. Juliana Bueno from the University of Chicago.
Okay. Good afternoon. Thank you so much for the invitation. It's really a pleasure to be here today. I have no disclosures, and I'm going to wait for this. So before I start, I do want to take a minute to acknowledge the role of mentors in our careers. I'm sure we've all found colleagues that we look up to and we've learned from. And it's really a privilege for me to share this session with one of my mentors in thoracic imaging, Paige McAdams. So it's really an honor, Paige, to share this with you. So let's address patterns of lymphadenopathy in common thoracic malignancies. As I said, I have no disclosures. And I have three main objectives today. So by the end of the lecture, hopefully, we're going to be able to recognize what is the clinically relevant pattern of lymphatic disease when we address three common thoracic malignancies. We're going to be able to identify what are those potential pitfalls in nodal staging, specifically addressing lung cancer. And overall, I want us to recognize what's the useful information that we want to include in our report to be participants and actually contribute to that management of our patients when we're staging these diseases. So regardless of the type of practice that you have, I'm sure that we all run into oncologic patients every day. And of course, diagnostic imaging has a really important role in the staging of these patients. Not only the diagnosis, but during that diagnosis, the primary staging is pretty much what's going to define the prognosis for these patients. And imaging has an essential role in nodal staging. These are usually lymph nodes that are not evident on physical exam. And by different imaging methods, we can actually define what's metastatic at the time of diagnosis. So it's important to do it right from the beginning. In this era of cancer genomics and targeted therapies, it's also really important to get good tissue biopsies. And we as radiologists participate daily on selecting the best site for tissue biopsies. So we also should know how to label these nodal stations. And of course, as therapies evolve, we see more patients surviving, and we get to follow them up, and the restaging of these patients in cases of recurrent disease also becomes important. So with this, I'm going to address the normal lymphatic drainage pathways of different organs in the chest, mainly as they become relevant for staging purposes in lung cancer, esophageal cancer, and breast cancer, and mostly emphasizing on some diagnostic pitfalls, some ways to work around those pitfalls, and some reporting tips. So let's just start with lung cancer, the leading cause of cancer-related deaths in the States, and really are daily read as thoracic imagers. So the different lobes in the lungs have different lymphatic drainage pathways, but we can actually generalize this in a very simple way. And knowing and understanding how these lobes drain has been really the basis of the creation of lymph node maps that are used for staging. So we can say that both upper lobes drain mainly into the hilar nodal stations on the right, then drain into inferior and superior paratracheal nodal stations. And on the left, the subaortic and paraortic nodal stations are involved after the hilum generally. Both lower lobes and the right middle lobe, after draining into the hilum, they drain into the subcarinal nodal station, and then they follow a similar pattern into paratracheal lymph nodes on the right, and then subaortic and paraortic lymph nodes on the left. So this understanding of the pattern of lymphatic dissemination has served as the basis of this nodal map. And this is the last version of the International Association for the Study of Lung Cancer lymph node map, which is the one that we use with the last version, the 7th edition of the TNM staging when we're staging lung cancer. And it's really beyond the scope of my lecture to go on detail on the anatomic boundaries, but I really want to encourage you to get familiar with the nomenclature and what are those anatomic boundaries, because the staging depends mostly on labeling these lymph nodes the right way. And it also facilitates communication of the information. We're speaking the same language with different specialties. So I'm not going to go into detail of the TNM staging, but I do want to emphasize what's the role of nodal staging in the overall staging of the disease. So as we can see here, let's just take a look at the nodal staging and how it impacts the overall disease staging. And as we know, staging determines prognosis. So it's important to know how we define this. So N1 disease is defined as ipsilateral peribronchial or ipsilateral hilar lymphadenopathy that is involved by tumor. Once the tumor involves the subcarinal and ipsilateral mediastinal lymph nodes, we say that there's N2 disease. When we have metastatic lymphadenopathy in the contralateral hilum and contralateral mediastinal nodal chains, we also define N3 disease. And if we find lower cervical lymph nodes on either side, that's also defined as N3 disease. So you can tell how it's important for us to know which lymph nodes are involved, because all of them change the staging, and of course the staging not only determines the prognosis, but also the management of these patients. So let's just start with the first diagnostic pitfall, a pretty simple illustration of the thoracic inlet. And one of the important factors here is differentiating lower cervical lymph nodes from superior paratracheal lymph nodes. So the anatomic boundary between these two nodal stations is the superior aspect of the sternal manubrium. And I wish the thoracic inlet was as simple as this illustration so we could differentiate it easily. But unfortunately, or fortunately, the thoracic inlet has an oblique orientation, so it's a much more complex area of the cervicothoracic junction. This sagittal illustration shows the orientation of the thoracic inlet, and we can actually take the first rib as the landmark, the anatomic landmark for where the thoracic inlet lays. So we said that the superior aspect of the sternal manubrium is the boundary, the anterior boundary between these two stations, but then posteriorly the superior paratracheal nodal station goes all the way to the apex of the lung. So you can see how there's an area of overlap when we look at axial images on CT, where we're not going to be able to easily define the location of these lymph nodes. And it actually makes a difference, because if we say that the patient has level 1 lymph nodes, which are lower cervical, we're saying this patient has N3 disease, which puts him in a stage 3B disease, which implies chemotherapy. So there's some impact on what we're saying. Let me show you in real life how this looks. So we have two examples here, two axial images, two different patients with lymphadenopathy in the thoracic inlet. And we said that the first rib is the anatomic landmark that we want to take. So let's look at the first rib, and if we create a horizontal line that bisects that rib, we can generally say that what falls anterior to this line that we traced along the first rib is going to be considered cervical. What falls posterior to that line, we can consider it mediastinal. So on the image on your right, you have an N3 disease, a patient who has a metastatic lymphadenopathy in his lower cervical, the scaling lymphadenopathy, and is considered as this N3 disease. Different from the image on the left, where if the tumor is on the right, this patient is going to have an N2 disease, because this falls behind this line and is labeled as a superior paratracheal lymphadenopathy. So just to simplify this learning point, a line bisecting the first rib typically separates the cervical region from the upper paratracheal nodal station, and we can use it as an anatomic landmark when we need to define where this lymphadenopathy is. So along these lines, one of the most important modifications of the last staging nodal map was the definition of a new anatomic boundary for defining right versus left when we're addressing paratracheal lymph nodes. And again, this is an example. So we have the superior and inferior paratracheal lymph nodes in this illustration. If we have a tumor on the right lung, then we have ipsilateral paratracheal lymphadenopathy, we can say this patient has N2 disease. If we're calling a contralateral lymphadenopathy with a tumor on the right, this patient is upstaged into N3 disease and stage 3B disease, which means he needs chemotherapy before his surgery and radiation. So again, this differentiation is important. This really becomes important for lymph nodes that fall anterior to the trachea, because as we know, we don't have a pretracheal nodal station. So one of the most important modifications of this map was the definition of an anatomic landmark, and we're using the left lateral wall of the trachea to define right versus left. So in this case, we have a patient with a right apical tumor. This pretracheal quoted lymphadenopathy falls into a right or ipsilateral lymphadenopathy, and this patient is classified with N2 disease. Different from this patient who has a cavitary lesion in the left upper lobe, we can see how there's a necrotic lymphadenopathy in the paraortic nodal station, and the same location of that lymphadenopathy in this case is going to be classified as contralateral disease, upstaging this patient to an N3 disease. So for lymph nodes that fall anterior to the carina, just remember that is the lateral wall and not the lateral wall of the trachea and not the midline, the one that defines what is right and what is left for these purposes. The last pitfall on lung cancer that I want to address, and I'm sure we all have seen lesions in the precarinal space. Again, we don't have a precarinal nodal station, so we have to define if these lymph nodes are either inferior paratracheal, which will be considered mediastinal, or hilar, which would be considered N1 disease. So this is kind of a gray zone of the staging system, because the precarinal space, it's really, the definition is not clear, but for managing, for treatment purposes, this is considered a mediastinal space. So lymph nodes in the precarinal space are not considered hilar. For treatment purposes, we're going to consider them as mediastinal. And that's for pitfalls on the lung cancer staging system. So let's move with esophageal carcinoma, also a pretty frequent malignancy that we see in the chest, pretty common factors, risk factors similar to lung cancer. And the esophagus is really one of those perfect organs for lymphatic dissemination. It has such a rich lymphatic network that creates easy dissemination to different sites of the not only chest but also the abdomen. So just as a general understanding, remember that the cervical esophagus and the superior third of the esophagus drain superiorly into the paratracheal nodal stations, and the two lower portions of the esophagus, they drain inferiorly, not only into paraesophageal lymph nodes but also paracardiac, supradiaphragmatic, and then into the abdomen. So there were relatively recent, 2009 revisions of the TNM staging system of esophageal carcinoma, kind of intending to harmonize the staging system with the one used for gastric carcinoma. And in this definition, in this new staging, they define new T for adenocarcinoma in situ, and then they are taking into account the histology of the tumor that changes the staging. But important for us today is the new definition of regional lymph nodes. So cervical and celiac lymph nodes are no longer classified as metastatic disease as they were before, and it is really the number of cancer-positive lymph nodes the one that defines the stage of the patient. And of course, this is going to be a combination of radiology and pathology after the patient has had the resection. So again, this is the end staging system, the last version for the TNM of esophageal carcinoma. And in esophageal carcinoma, nodal disease is the most important prognostic factor. And it's the most important prognostic factor because it has been demonstrated that the 5-year survival rate in patients who have negative lymph nodes mostly depends on the T, on the tumor, the type of tumor, the size of tumor, and the degree of local invasion of that lesion, and the histology. But if the patient has positive lymph nodes, then the survival directly depends on the number of cancer-positive lymph nodes. And here we're aware of the limitations of CT for defining pathologic lymphadenopathy. We fortunately have endoscopic ultrasound and PET-CT, which have demonstrated much more accuracy, a higher accuracy for these purposes. And we can use it for defining what are those lymph nodes that are involved. But how can we add value to our report then if we're staging these patients and assessing for the first time these patients? So the frequent sites of lymph node metastases at the time of surgery, at the time of diagnosis, are usually cervical lymph nodes along the paraesophageal nodal stations, then paracardiac and intra-abdominal are mainly along the lesser curvature of the stomach. So make sure to look for those lymph nodes when you're staging these patients, trying to look for metastatic nodal disease. If you're assessing a patient who already had surgery, which is usually esophagectomy, gastric pull-up, and nodal dissection, then the disease recurrence is mostly going to be in those areas that were not dissected at the time of surgery, meaning lower cervical lymphadenopathy, and then celiac and abdominal periodic lymphadenopathy, which are not routinely resected. So as a learning point for esophageal carcinoma, just remember that it is the number of positive lymph nodes and no longer the location what is going to define the end stage of these patients. And then last, breast cancer, also a pretty common malignancy among women. Second cancer-related death in the States, and it's it follows lung cancer. And really here, imaging and we as radiologists have an important role in not only defining the diagnosis of these patients, but giving clinical information that is going to impact the management. So let's just remember the breast, the three main drainage pathways for lymphatic drainage of the breast. We have the axillary nodal groups, we have transpectoral lymph nodes, and we have internal mammary. So if you remember from anatomy, the external portion of the breast mainly drains into axillary lymph nodes, and these axillary lymph nodes are separated in three different groups by the minor pectoralis muscle. And then the medial aspect of the breast mainly drains into internal mammary lymph nodes, and then they all drain into cervical lymph nodes. In patients with breast cancer who already have recruited all these nodal stations and the tumor obstructs these nodal stations, then there's recruitment of contralateral internal mammary lymphadenopathy, and then the disease spreads into the abdomen. So again, the most important data that we can give here is going to impact definitely the overall staging of the patient. So defining nodal disease is not only going to impact that overall staging, but it's also going to define the surgical management of these patients. It's going to define which patients are eligible for surgery as first line of treatment, who's eligible for chemotherapy, or who needs radiotherapy. All of these depending on the information that we give. And more than memorizing the nodal staging system, I think it's important to take into account which are those nodal stations that are going to impact that decision of which treatment the patient is going to get. And there's some clinical exam involved in the classification of breast cancer. So we as radiologists, this is one of the most common sites of nodal metastasis, axillary lymph nodes. What information we can give is just the position of the lymph nodes, the presence of local invasion of the minor pectoralis muscle by a metastatic lymphadenopathy, which is not infrequent. But the definition between N1 and N2A disease is mostly going to be secondary to the physical exam if there is mobile or fixed lymphadenopathy. The internal mammary lymph nodes are not palpable, and this is part of our role, looking for those lymph nodes. Just remember that we normally don't see internal mammary lymph nodes. So any enlarged lymph node is going to be pathologic. We don't use the 10 millimeter that we use for mediastinal lymphadenopathy. In this case, we have a mass in the external quadrant of the breast, metastatic lymphadenopathy, and you can see how this patient also has internal mammary lymphadenopathy. So just make sure to look and scan all the way along the internal mammary nodal chains to look for disease. Interpectoral lymph nodes, they're not they are not taken into account for staging. It doesn't really change the staging of the patient, but they are commonly involved, as this is one of the drainage pathways of the breast. It's important to include it in the report because they define and modify the radiation field. So if the patient has interpectoral lymph nodes, which means lymph nodes between the major and minor pectoralis muscles, this is going to impact the decision on treatment and how they are going to plan the radiotherapy. So remember to include it in your report as well. And then when we're following patients with breast cancer, nodal disease recurrence is unfortunately one of the most frequent types of recurrent disease. We can see how this patient already had nodal dissection in her axilla, probably focal local radiation. We can see an area of radiation fibrosis and a metastatic lymphadenopathy in the internal mammary nodal chain, which is a very frequent site of disease recurrence. So, learning point for breast cancer, remember that the interpectoral lymph nodes are not considered in the staging, but reporting them, it's important because they are going to impact the radiation therapy planning. And the internal mammary lymphadenopathy, they're pretty much our job to find these lymph nodes. They are not palpable on physical exam. They definitely upstage the patient into an N3 disease at least, and they are a very common site of recurrent disease. So let me just conclude by saying that the regional lymph node status, as we see, is very important for staging and also defines the treatment. And I hope that we can get the understanding that staging should be done correctly because it's a really important prognostic indicator. So the information that we're giving really impacts what's the decision, the next step with these patients on their treatment. And then, of course, we can only stage appropriately if we have knowledge of the lymphatic drainage pathways and the nodal staging systems. So get familiar with those systems to improve your accuracy. Thank you so much for your time.
Thank you very much, Juliana. By the end of my talk, 100 patients in emergency departments around the US will have undergone CT pulmonary angiography. That's according to a study by Niska and colleagues in 2007. And it demonstrates how popular CT pulmonary angiography is. And the reason behind that is from PIOPED-2 data and more recent experience, CT pulmonary angiography has a very high sensitivity and specificity for pulmonary embolism. There are, however, some caveats attached to the frequent use of CT pulmonary angiography. Anticoagulant therapy carries with it a risk of major hemorrhage, so it's crucial that the diagnosis of acute pulmonary embolism is correct. There's also a broad range of reported radiation doses associated with CTPA, and it's important that dose be kept as low as possible in this commonly used test. In addition to this, recent literature suggests that pulmonary embolism overcall can occur due to beam hardening and motion artifacts, which is a major challenge in critically ill patients. And with the improving spatial resolution of CT, we're now diagnosing smaller and more peripheral PEs without data to guide us on whether these should be treated the same as larger pulmonary emboli. So it's for all these reasons that I'm going to describe the imaging features of acute and chronic pulmonary embolism, tips to avoid overdiagnosis and reduce radiation dose, the current controversies surrounding a CT diagnosis of PE, and some novel techniques which may help address these challenges. The features of pulmonary embolism in the acute phase include complete arterial occlusion, as seen in this case, with failure to opacify the entire lumen of the arteries, which also may be enlarged in comparison to pulmonary arteries of the same order of branching. Acute PE can also appear as a central filling defect producing the Polemin sign, as seen in this patient. And if seen in long axis, can give a railway track appearance. On lung windows, peripheral wedge-shaped areas of hyperattenuation represent infarcts, and linear bands of atelectasis can also be seen, and these have both been demonstrated to be statistically significant ancillary findings in PE. Chronic pulmonary embolism, on the other hand, manifests as a broad-based, smoothly marginated, eccentric neural filling defect, which often forms an obtuse angle with the vessel wall, as seen in this case. In addition to this, you may also observe dilated pulmonary arteries, a contracted, obliterated artery peripheral to the site of chronic obstruction, as seen in this case. And on lung windows, you'll also see areas of radiolucency or oligemia. You see this very small vessel here in this very lucent portion of lung, which is the CT manifestation of the Westermarck sign. In chronic pulmonary embolism, you may also see linear filling defects, as in this case here, in the basal arteries of the left lower lobe. Additional indirect signs include a dilated pulmonary artery, tortuous vessels, enlargement of the right atrium and right ventricle, straightening of the interventricular septum, and occasionally lymphadenopathy, as seen in this case. Overdiagnosis is a term which refers to an incorrect diagnosis of PE in the setting of an artifact or a pathologic mimic of PE. This can be due to motion artifact, transient interruption of the contrast bolus, and other pathologic mimics that I'll discuss now. The image on the left, when viewed in isolation, might be misinterpreted as multiple non-occlusive pulmonary emboli. In these cases, I'm careful to look at the lung windows, where I can clearly see a double density along the lateral edge of the mediastinum and indistinct pulmonary vessels, indicating that this is in fact respiratory motion artifact and not pulmonary embolism. Respiratory motion is a particular problem in the dyspneic patient who may not be able to breath hold. This 53-year-old male underwent this CT here on the left, which showed motion artifact in the left lower lobe. I was concerned because of the presence of a pleural effusion and atelectasis in that region that there might be a pulmonary embolism that I could not see. So the initial scan had been performed in the craniocaudal direction, but I brought the patient back, and with coaching and caudocranial scanning, we minimized the amount of motion artifact in the left lower lobe, and we were able to exclude pulmonary embolism. Cardiac motion can also cause apparent filling defects in the lung parenchyma close to the heart. This is a CT in a 34-year-old female who was in the 3rd trimester of pregnancy and presented to the emergency department with right-sided chest pain. The overnight read was that of acute pulmonary embolism in the lingula, as seen in this area here, where there is low attenuation in the pulmonary artery, which is lower than that of the adjacent left lower lobe pulmonary artery. However, as is standard in my hospital, the fetal maternal medicine service reviewed the patient and the CT with a subspecialty radiologist the following day. Their clinical suspicion was that pulmonary embolism was unlikely, and this was supported by the finding that the apparent PE was close to the left ventricle, and there was a double density along the margin of the left ventricle. So it was concluded that, in consensus, she probably did not have a pulmonary embolism on the contralateral side of her pain, and she was discharged on prophylactic low molecular weight heparin until 6 weeks after delivery, and had no thromboembolic episodes on follow-up. This is another case of a pregnant patient with dyspnea in the 3rd trimester of pregnancy. The CT shows an ill-defined area of low attenuation in the interlobar artery, and the coronal reconstruction shows a large bolus of unopacified blood in the right atrium. This supports the suspicion that this is actually transient interruption of the contrast bolus by unopacified blood that has been sucked up into the right atrium, and is a common artifact when a vigorous deep inspiration is performed by particularly pregnant patients. This can be minimized by careful patient coaching to encourage a shallow held breath rather than a deep held inspiration. Pathologic entities can also be challenging to differentiate from pulmonary embolism, and these include mucoid impaction, which is manifested as multiple branching low-density structures along the bronchovascular bundle, and can be misinterpreted as pulmonary embolism. As in this case of a patient with severe COPD, bronchial wall thickening, and these filling defects within the airways, and looking at consecutive contiguous images in the lung windows can help clinch the diagnosis of mucoid impaction rather than pulmonary embolism, as was initially suspected. Treated pulmonary embolism may also cause confusion, as in this case of an elderly gentleman who presented to the emergency department after a syncopal episode. He was unable to give a history himself, but the physician who assessed him felt that he was dyspneic on arrival. So a CT pulmonary angiogram was performed. And this subtle filling defect in the right upper lobe was called as an acute pulmonary embolism given the provided history. The following day, however, the referring clinician reviewed the patient and got a collateral history, which was positive for a recent intracranial hemorrhage and a remote history of a treated pulmonary embolism in the right upper lobe. Fortunately, we were able to source a prior CT pulmonary angiogram from 18 months prior, and it confirmed that he did have an acute pulmonary embolism a year and a half ago, and coupled with the fact that the referring physician did not feel his dyspnea was severe or any different from baseline, and the fact that he had a recent intracranial hemorrhage, a decision was made not to administer therapeutic heparin for this patient. And he had no recurrent episode of thromboembolism after discharge. Tumour involvement of the pulmonary arteries can mimic pulmonary embolism, as in this case, and PET-CT or contrast-enhanced MRI may help differentiate between tumour and intraluminal thrombus, where there is debate. The best way to reduce radiation dose is to avoid unnecessary CT studies. The overuse of CT in suspected pulmonary embolism has been widely reported. One such study by Perellis and colleagues analysed 646 patients who found that half of all CTs analysed could have been avoided had the ESC guidelines for suspected pulmonary embolism being used, which state that in patients with low to intermediate risk of probability based on risk factors and a negative D-dimer, that CTPA should not be performed. There are many clinical decision rules that can be used, such as these 4 clinical decision rules, and it has been shown that using clinical decision support reduces the incidence of uses of CT by 20% and increases the incidence of PE from 4 to 9%, and that was reported by Rajas and colleagues in Brigham and Women's Hospital. If there is, however, an indication to use CT, there are a number of steps that can be taken to reduce dose. CT can be performed at 80 or 100 kVp to better use the K-edge of iodine at 33 keV, where there is greater photoelectric absorption. This has been shown to produce images of diagnostic quality, particularly in patients less than 100 kilograms, and produces images of comparable image quality to those at 120 kVp. In my department, we use 80 kVp for pregnant patients and 100 kVp for non-pregnant patients, and with iterative reconstruction, we're able to deliver CTs at a dose of less than 2 millisieverts with excellent image quality. Contrast monitoring also contributes to the breast dose because it requires the repetitive imaging of the region of the breasts. Although it does not contribute a large portion to the overall DLP, a study by one of my colleagues, Peter McMahon, recently published in the European Journal of Radiology, concluded that the contrast monitoring portion of a CTPA contributes to 27% of the overall breast dose when performed at 120 kVp. He went on to decrease the kVp for the contrast monitoring portion of the CT and showed that it then at 80 kVp contributed to only 7% of the total breast dose. Reducing the z-axis of the CT range has also been shown to reduce radiation dose. One such report describes a 37% reduction in radiation dose. However, there is potential to miss either a PE or an alternate diagnosis that may help patient treatment. And in one particular report by Mikolakis and colleagues, using a 10 centimeter z-axis, 2% of PEs were missed and 17% of alternate diagnoses were missed. For this reason, I suggest that a reduced z-axis only be used in pediatric and pregnant patients. So in summary, clinical decision support, a low KVP CTPA and reduced Z-axis in special situations can help reduce radiation dose in this commonly used test. Overdiagnosis has come under the spotlight because it has been noted that PE incidence has risen from 5% to 9% over a 10-year period, while mortality from PE has remained relatively static. This has interestingly coincided with the advent of multi-detector CT, and this graph shows this relationship where the blue squares represent the incidence of pulmonary embolism from 1994 to 2006, with the mortality remaining static. And there's no doubt this relates to the increased sensitivity of multi-detector CT. The topic of overdiagnosis was addressed by a large retrospective study of a cohort of 937 patients by Hutchinson and colleagues, reported in the AJR last year. And it looked at this large group of patients who had been given a diagnosis of pulmonary embolism. All of the positive cases of PE were then reviewed by a 3-member subspecialist board working in consensus. And the diagnosis of PE was actually refuted in a quarter of all patients. The refuted PEs were predominantly solitary, segmental or subsegmental, and half of all solitary PEs were refuted on review. False positives were largely attributed to beam hardening artifact and motion artifact. It's therefore important that the PE mimics that I described earlier on are excluded prior to making a diagnosis of pulmonary embolism, and that clinicians have the facility to get a second opinion, particularly when the clinical history is discordant or in patients where the use of anticoagulation would be particularly problematic for clinical reasons. Overtreatment is a concept that small pulmonary emboli in subsegmental vessels may not merit treatment when a risk-benefit analysis of anticoagulation versus no treatment is considered. This thinking has emerged as a result of the increasing incidence of subsegmental pulmonary embolism, particularly in the absence of robust data to support its treatment. One such study describes a retrospective review of over 2,000 patients in Canada by Goy and colleagues, and it reported that isolated subsegmental pulmonary embolism was identified in 4% of all their patients. Half of those patients had received anticoagulation and approximately half had not. In those patients that had received anticoagulation, there were 2 life-threatening abdominal hemorrhages, and in the patients who did not receive anticoagulation, there were no recurrent events of thrombosis. Interestingly, an alternative diagnosis to explain the patient's symptoms was identified in 67% of patients with subsegmental pulmonary embolism. There is, however, conflicting evidence in the literature. A small study by Kligerman and colleagues describes 53 patients who, when their CT pulmonary angiograms were analysed by a CAD system, had PEs detected that were missed by radiologists. Of those patients, 14 represented with a new pulmonary embolism, and 9 of those 14 patients had isolated subsegmental PEs. So what should we do about these patients in this controversial area? Well, a meta-analysis in 2014 looked at 5 retrospective cohort studies and divided the groups into untreated and treated patients. In the treated patients, as I alluded to previously, there were 9 major bleeds, and in the untreated group there were no documented deaths or recurrent pulmonary emboli. This meta-analysis suggested that it's safe to withhold treatment if there is no evidence of DVT, if there's a major risk factor that has been resolved or treated, such as cancer, and if there is no central venous catheter or atrial fibrillation. It's important to acknowledge, however, that if a patient has an ongoing malignancy, they are treated differently, and it's more appropriate that they would be anticoagulated. And moving on to novel techniques for pulmonary embolism imaging, I'll discuss dual source CT and dual energy CT, but MR pulmonary angiography will not be discussed due to time limitations and its lack of clinical widespread use. Dual source CT uses 2 orthogonally mounted X-ray tubes and detectors to double the speed of image acquisition, and it achieves high temporal resolution with pitch factors of up to 3. This allows the continuous volume coverage of the whole thorax in less than 1 second. The major advantage is fast acquisition, leading to significant motion reduction, and potentially, but not consistently, lowering of radiation dose. You can also use less contrast if there is a concern about nephropathy. And there is, because of the speed of scanning, a superior depiction of cardiac structures if a triple rule-out is desired. And this is a case from the literature showing a bilateral pulmonary emboli, and the images are notable for their lack of any pulsation artifact adjacent to the heart. Dual energy CT can be acquired using dual source CT or a single source CT with a gemstone detector. And it comprises image data which is acquired at 2 different peak kilovoltages. The image data from both energy levels are then combined to form a hybrid image, which is equivalent to a scan that is approximately halfway between the 2 kilovoltage levels. And these can be used for diagnostic evaluation of morphology and anatomy, in addition to producing an iodine map, which will show perfusion defects in the lung parenchyma. The facility of this is that a small subsegmental pulmonary embolism, which may be imperceptible by CT, is then better identified because a large area of decreased contrast enhancement can be interpreted on the iodine map images. And it potentially increases the sensitivity of CTPA, although data is still awaited. These images were given to me by Dr. Shauna McDermott in MGH, where dual energy is used for diagnosis of pulmonary embolism. And it shows a dual energy images at 80 kVp and 150 kVp, where the patient received only 36 cc's of iodinated contrast in a case of a patient with renal dysfunction. There is excellent attenuation in the pulmonary arteries on the low kVp image on the left. This fused image of both the prior images shows that they can be used in combination to amplify contrast enhancement in the pulmonary arteries, while also being able to see the mediastinal contour as well because of the higher dose images that were required. This dual energy, or this patient is a 36-year-old female who had shortness of breath over an 18-month period, and she had a prior history of pulmonary embolism for which she was still being treated, and the diagnosis was made 18 months prior. The chest X-ray shows the increased body mass index and cardiomegaly, and her CT shows bilateral occlusive pulmonary emboli in both lower lobes. A right heart catheter study that was performed confirmed pulmonary hypertension. The dual energy images from that scan were used to produce the iodine map that I'm showing here, which shows extensive bilateral lower lobe perfusion defects. These were also apparent on perfusion scintigraphy, and she had a normal ventilation scan. This composite image of the angiographic CT plus the iodine map beautifully depicts the extent of vascular occlusion. And it is possible, although it remains to be seen, that such images may obviate the need for perfusion scintigraphy in the future. In summary, it's crucial to correctly identify pulmonary embolism, avoid overdiagnosis due to mimics, and minimize radiation dose, and have an awareness of the current controversies and novel techniques that may help address the challenges of pulmonary embolism imaging. Thank you very much. The organisers must have decided on a theme, because I also get to introduce my mentor from fellowship, Dr. Diana Litmanovich, who will speak on the evaluation of patients with hemoptysis.
Carol, thank you very much. It is indeed a pleasure to share the same session with your mentee. And thank you very much for inviting me to participate in this course. In the next 20 minutes or so, I would like to switch gears and to talk about another tubular structures in the chest. We are switching from pulmonary arteries to airways. So let's focus on the airway imaging in hemoptysis. The objective of this talk would be to focus on the airway pathology, which is associated with hemoptysis, to talk about primarily CT findings, but also some chest radiograph findings in central and peripheral airways in patients with hemoptysis, and also to talk about some specific protocol considerations for MDCT imaging, as well as to discuss the currently appropriate criteria for imaging of patients with hemoptysis. So what is hemoptysis? If we think about it, it's actually a bleeding which originates from the lower respiratory tract per definition. It can be one-time episode or it can be recurrent. And it varies in severity from some minor hemorrhage to a massive life-threatening bleeding. The important point is that the workup is required for any type of hemoptysis, even a one-time episode and even a very minor hemoptysis. And hemoptysis is a symptom. And like any other symptom, imaging of hemoptysis should focus on discovering the cause, the source of a symptom, and the consequences of a symptom. So the initial goal of imaging would be to identify the immediate source and consequences of bleeding in order to treat them immediately if needed. But the ultimate goal is to identify the primary cause, which unfortunately is unidentified in about 40% of patients. Now, if we think about the consequences of a symptom, and in this case, the consequences of major hemoptysis, it will be airway compromise. In addition to the airway compromise, when we have bleeding within the airways, there will be a parenchymal bleeding, which is rarely a cause of substantial symptoms or consequences. So that's how a clot of a major hemoptysis, which is extracted from the airway, can look like, and it obviously can be a substantial problem in terms of breathing and compromise of the airways. Now, the source of bleeding would be either endobronchial lesions or parenchymal lesions. And the bronchial lesions usually will be bleeding from the bronchial or systemic arterial circulation. And parenchymal lesions will be bleeding due to involvement of the pulmonary arterial circulation. Massive hemoptysis is usually caused by bronchial arteries. And mild or moderate hemoptysis, again, usually can be caused by bronchial arteries, but also the pulmonary arteries, frail mucosa, or endobronchial granulation tissue. So again, the massive hemoptysis episode will be in the vast majority of cases caused by the bronchial or systemic arterial circulation. Bronchial arterial hypertrophy is the major cause of the bleeding, and in 90% of cases of hemoptysis that requires intervention with arterial embolization or surgery would be due to the bleeding from those bronchial arteries. The acute thromboembolic disease is a frequent cause of non-massive hemoptysis, and the pulmonary artery direct invasion by the neoplastic disease would be another common cause of the bleeding due to involvement of the pulmonary arteries. Other problems such as necrotizing inflammatory disorders, for example, like tuberculosis with transmucin aneurysm, would be another potential cause of the pulmonary arteries causing hemoptysis. So if we look at the vast majority of the causes of hemoptysis, we can divide them into three categories: the tracheobronchial, the ones that I'll be focusing on, the parenchymal, and the vascular. So the airway diseases actually now is the most common cause of hemoptysis in developed countries. And we can differentiate them into two groups. One is common and the other one is uncommon, not necessarily rare, but less common entities. And within the common entities, bronchiectasis and chronic bronchitis are probably the most frequent one that we encounter in our regular practice, followed by neoplasm, tuberculosis, and trauma. Evaluation of hemoptysis. So we are evaluating hemoptysis usually with MDCT versus bronchoscopy that is done by pulmonology or interventional pulmonology specialists. So what are the advantages of bronchoscopy? So some of them are quite obvious. They're capable of localizing bleeding, they can do the tissue diagnosis, and they can control the airway in patients with catastrophic hemorrhage. What are the advantages of MDCT? Definitely capable of localizing bleeding, actually better than bronchoscopy. They are more effective in detecting the underlying causes such as bronchiectasis or neoplasm, and they also provide a detailed roadmap of the airways with 2D and 3D reconstructed images that can be further used for actual bronchoscopy. They can also demonstrate extraluminal complications, which are impossible with regular bronchoscopy. So let's start with talking about a very common cause of hemoptysis, such as bronchiectasis. And this is one of the typical cases of bronchiectasis in this 72-year-old male with recurrent hemoptysis and cough. So we can see that the chest radiograph shows us a mass which is projecting over the left lower lung, and on the CT examination we can see much better the actual cause, which is cylindric and cystic bronchiectasis with air fluid level. Very typical picture of patient with bronchiectasis. So what is bronchiectasis? It's permanent and abnormal dilatation of the bronchi that can be of three major types: cylindrical, varicose, and cystic. And 50% of patients have hemoptysis, which is quite large number. So every second patient with bronchiectasis will have at least one episode of hemoptysis. Usually it's a result of bronchial artery enlargement due to chronic inflammation of the wall. The idiopathic bronchiectasis are quite common, and they have a lower lobe predominant. And there are multiple other causes of bronchiectasis with various distribution within the lungs. Important one to discuss would be atypical mycobacterial infection, because it's another quite common cause of bronchiectasis. It's quite common. Hemoptysis is rare but can happen in this specific group of patients, which are usually women which are more than 60 years old. The distribution is quite typical, with frequent involvement of the middle lobe and lingula. And again, the bronchiectasis in conjunction with chronic infection will cause dilatation of the bronchial arteries, granulation tissue, and bleeding. When we come to focal bronchiectasis, things become slightly more involved, because basically any cause of airway obstruction can lead to focal bronchiectasis. It can be either due to extrinsic compression, endobronchial malignancy, foreign body, or bronchiolitis. What is important that focal bronchiectasis in conjunction with hemoptysis would require diagnostic bronchoscopy in almost 100% of cases, because we do not want to miss those causes such as malignancy or foreign body that can be both diagnosed and sometimes, in case of foreign body, even treated with bronchoscopy. So hemoptysis in bronchiectasis is due to both focal and diffuse bronchiectasis. It can be the presenting symptom. And also with focal bronchiectasis, we have to exclude obstruction. With a typical mycobacterial infection, the bronchiectasis can be a rare but definitely considerable cause of hemoptysis. So let's talk about chronic bronchitis, another very common cause of hemoptysis. And I'm going to show you two totally unrelated but very similar cases in terms of history and imaging findings. So the first one is a 66-year-old woman with long smoking history and recurrent hemoptysis, and we can see secretions in the major airways. We can see the thickening of the airways at the level of the subsegmental bronchi with some minimal degree of bronchiectasis, but the main focus is secretion and the thickening of the airways. Another patient, 78-year-old man with long smoking history and recurrent hemoptysis, real patients, real histories, very similar findings. Secretions, thickening of the airways, and some areas of air trapping. So typical patients with chronic bronchitis and hemoptysis. So more than 40% of patients with chronic bronchitis, quite similar to the 50% in patients with bronchiectasis, will have hemoptysis. And the cases of chronic bronchitis is due to the bronchial artery enlargement, but also due to the irritation of friable and vascular mucosa. So the bleeding is happening frequently, usually with a very small amount and in different parts of the airway tree. Okay, so we see the diffuse bronchial wall thickening, and we also can see sometimes tree and bud opacities, which actually may be the representation of the hemoptysis into the small airways. Let's look at the very specific patient with a particular cause of bronchial wall thickening, such as alpha-1 antitrypsin deficiency, where we see patient with diffuse bronchial wall thickening, as you can see in the lower lobes. We see some degree of bronchiectasis, and we see obviously the specific distribution of emphysema being more predominant in the lower lobes. So those are patients which we do not see frequently, and they don't frequently have hemoptysis, but definitely can be associated with this disease and should be kept in mind. Let's switch gears and talk about another potential cause and imaging findings in patients with infection. And obviously, when we think infection and we think hemoptysis, the next thing that comes to our mind is tuberculosis. And this is a case of a patient with primary tuberculosis. We do see airway involvement by active infection. We can also see the typical appearance of the consolidation with a central cavitation and substantial narrowing by the direct involvement of the infection. Hemoptysis at this stage is surprisingly relatively rare, but it becomes way more frequent when we are talking about a fibrotic stage or secondary tuberculosis because there is involvement of the airways by the bronchiectasis, bronchiolitis, and airway obliteration, where the hemoptysis becomes substantially more often. Rare but known cause of infection, and we should say inflammatory reaction, is the case of severe allergic bronchopulmonary aspergillosis. It doesn't happen very rare. It should probably be considered in less than 5% of patients, but in advanced cases of ABPA, where we have involvement of the airways in multiple areas of the lungs, long-standing and irregular, like in this case, which is probably one of the most severe cases of ABPA I have seen, the hemoptysis is definitely something that can be expected. Now let's switch gears to another very common cause, such as neoplasm. So this is one of the rare cases where we have a large tumor involving the trachea, and this patient actually presented with dyspnea, not with hemoptysis. But that would be a definitely known cause and very frequent cause of hemoptysis. We can see extensive involvement of the thorax by malignancy. And we know that the majority of the airway neoplasms in adults are malignant. The hemoptysis can be seen in more than 50% of those cases, which are usually associated with neovascularity and very friable vascularity within the tumor itself that tends to bleed. The primary neoplasms are substantially less frequent than the metastatic disease in adults. And if we're talking about the trachea, the two most common primary neoplasms would be squamous cell and adenoid cystic carcinoma. This is an example of adenoid cystic carcinoma, where we can see how much of the mass is protruding into the airways, into the trachea, and definitely friable and prone to bleeding. Another case of the adenoid cystic carcinoma, also substantial involvement of the airways. I have presented those two cases yesterday in the panel of the unknown cases, and the reason I'm bringing them is because they're relatively infrequent, but they should be remembered and they should be considered as potential causes of hemoptysis. This is another patient who has been first scanned due to incidentally discovered pulmonary nodule. I think it was in the left lower lobe. And diligently, we have invited him for a follow-up, and then for another follow-up. And only a substantial time later, when he came for his actual 1-year follow-up scan, we paid attention to the fact that there is a nodule within the trachea, which is growing slowly but surely between the January of 2014 and January of 2015. And when talking to the patient, he did provide us a history of maybe hemoptysis. He didn't pay attention, was a little bit, but then the diagnosis of this case showed squamous cell carcinoma. So when we have a history of hemoptysis, we have to scrutinize airways, because sometimes even very small tumors can be a cause of hemoptysis. Metastatic neoplasms of the airways can be either due to hematogenous spread, like in the case of breast cancer, or sometimes can be due to direct involvement, like in the case of the lung cancer, in this case where lymph nodes are eroding into the trachea. This is another unfortunate patient with a relatively uncommon disease, but a disease which can very commonly and almost invariably all cases be a source of hemoptysis, such as advanced esophageal cancer with the fistula between the esophagus and the trachea. This is due to the esophageal cancer in 10% of the cases, and in other cases it could be tracheal neoplasm, metastatic lymph nodes, lymphoma, or radiotherapy. But as you can see, the neoplasma malignancy is involved in the vast majority of the cases, and they have hemoptysis, and unfortunately 100% will be associated with aspiration and contamination of the entire respiratory tract. This is another patient with malignancy, and you can see it on the ray, and you can also see it on the CT. In this case, it's a young patient, and the history was recurrent hemoptysis. What we see is a mass in a very close proximity of the left lower lobe airway. So this is a typical presentation based on the age and the appearance of the carcinoid tumor. In those patients, hemoptysis is a very common complication, and this happening again due to the hypervascular stroma within the carcinoid. They are centrally located, narrow the adjacent airway, and they are markedly enhancing. Massive hemoptysis is rare, but because it's not an easy tumor to diagnose with percutaneous biopsy, it can be done with transbronchial biopsy. And during the biopsy, the hemoptysis is a very frequent complication, which altogether will be happening in the half of those patients. And now let's talk about other or maybe more rare cases of hemoptysis. And I would like to start with this patient who has bronchiolitis. This is a known cause of hemoptysis. Fortunately, it's a benign cause of hemoptysis, but very frequent. And this is usually due to infected calcified lymph nodes, which are caused in the vast majority of cases by histoplasmosis. The hemoptysis is usually in coexistence with bronchiectasis, but not necessarily. They are more commonly involving the right lung, but it can also be in any part of the lung. And what is important is to use multiplanar reconstructions due to the fact that they help us to identify the precise location of the abnormality. As you can see, the multiplanar reconstruction helps us to place the abnormality right within the airway. So we know that the abnormality is within the airway, and in this case, it's not a granuloma, but it's actually a bronchiolitis. Another patient with cough, and I like to show this case because it's really not a common finding, but something that we should look for. And when the patient was imaged with CT, and as you can see, her chest radiograph was not really revealing, but with the CT, we can clearly see an abnormality within the airway of her right lower lobe, very well demarcated, very precise, with air trapping on and expiration. This was a fishbone that was successfully retracted, but this is another common cause of hemoptysis. Foreign body aspiration is unusual in adults, and it's often overlooked as a cause of airway obstruction. It may be clinically silent, but massive hemoptysis may develop, especially if the foreign body penetrates the adjacent vessel. The radiological manifestations are of chronic volume loss in the affected lobe, recurrent pneumonias, bronchiectasis, and also chronic inflammatory reaction around the inhaled material with intrabronchial mass formation. Let's look at the next case in a patient which is young, which has a very abnormally looking airways, both central airways as well as intraparenchymal airways, and has hemoptysis. This is a laryngotracheobronchial papillomatosis. We have multiple benign squamous papillomas throughout the airways. They can undergo malignant degeneration, and they can cause hemoptysis. Less than fifths of the patients, but still a cause of hemoptysis. What it's important to remember is to see them on the MDCT and to look for involvement of both airways, central airways, and lung parenchyma. Another patient that has presented with hemoptysis during the long course of his known disease is a patient with what is used to be called Wegener granulomatosis, and now it has a GPA, it's a different name, but you can see massive involvement of the airways, and due to the very fragile mucosas, those patients tend to bleed, not with massive bleeding, but with recurrent episodes of small hemoptysis. Now, what is important again to remember that those patients have a subglottic stenosis, which is relatively long, but they can also have areas of involvement elsewhere in the airways, and the hemoptysis can be caused by basically any airway portion that can be involved by the disease. So how do we image those patients? With the variety of pathologies I have presented, we can actually come down with a relatively uniform protocol. We can use either non-contrast CT in patients that are unable to undergo CTA, or what is preferable is CT angiography. We always have used thin sections of the axial slices, and the MPRs and the 3D reconstructions are necessary. Again, what is extremely important to remember that the bleeding can be actually at any portion of the airways, and that's why the scan should be from the base of the neck to the level of L2. The KVP and MAS, thinking about radiation dose reduction, should be BMI based, and again, very narrow collimation of 0.5 is important. Relatively high pitch can be used because it actually provides us enough of the resolution. And when we are injecting IV contrast, we should think about it as a CT angiography and do it at least as 4 milliliters per second. Now, the reconstructions are extremely helpful, and I will show you a couple of examples because they're defining the complex anatomy and subtle pathology. They can also delineate the length and the shape of the abnormality, and they're more visually accessible and anatomically meaningful, especially for the clinicians who are going to treat the patient. So when we are talking about the reconstructions, we have to remember about the MINIPs, or minimal intensive projection images, the curved multiplanar reconstructions, the 3D surface rendering, or in other words, virtual bronchoscopy, and the 3D external volume rendering reconstructions. For example, this is a scan which is done after that with post-processing and minimal intensity projection images were created. We can appreciate how much easier we can see the subtle bronchiectasis in this case, as well as more appreciable the combination of the bronchiectasis and emphysema. Curved multiplanar reconstruction, the same case of bronchiolitis I have shown earlier. We can see how the airways are located in relationship to the structure. Is it within or outside of the airway? And the lung segmentation volume rendering with transparent airways, it's another very important technique. We can appreciate on this axial image an extensive involvement of the mediastinum by a malignancy. But when we are looking at the 3D reconstruction, we see how much of the airway is narrowed, where the narrowing is located, and the relationship of the mass in comparison to the trachea and to the bronchus. So what is the role of virtual bronchoscopy? So it's an alternative in a way to bronchoscopy because it helps us to avoid invasive procedure in pediatric population and in frail elderly. And it's also a confirmation of an anatomical variance that sometimes are difficult to pick up with conventional bronchoscopy. It's actually complementary to bronchoscopy because it can guide bronchoscopic biopsies. It helps with pre-procedural planning and post-procedural evaluation and surveillance. And also, what is interesting as the use of it, it can help us to assess distal airways beyond the high-grade narrowing. This is a patient with a very large proximal neoplasm, and actually conventional bronchoscopy was impossible in this patient with any type of the skull. And by applying the virtual bronchoscopy, we can actually look in a very comprehensive way in the more distal airway tree. So what are the current ACR appropriateness criteria for imaging of hemoptysis? So first of all, the chest X-ray is the initial stage of evaluation. It helps us with lateralization and the underlying parenchymal or pleural abnormalities. So chest X-ray must be done. The next to be used in frequency and in order is contrast-enhanced MDCT, again in localizing the site of bleeding, the underlying disease, and the simultaneous assessment for bronchiectasis and malignancy. It could be done if patient is stable. And then thoracic aortography for bronchial artery embolization could be only done for treatment and should not be done for diagnostic purposes. Let's look at a couple of the clinical scenarios. The first one is a patient with hemoptysis, where the hemoptysis is moderate, it's not minor, but it's not massive, and the patient has risk factors. For example, he is older than 40 and has a substantial smoking history. So in those patients, actually it has been shown that MDCT would detect neoplasms in 5 to 10 patients, and it has a higher yield than bronchoscopy in detecting the cause of hemoptysis. What is important to remember, and I have mentioned that in the beginning of my talk, is that even one episode of hemoptysis requires investigation. The next clinical scenario is the patient with persistent or recurrent hemoptysis, which is small and has one risk factor. So in this case, we can see that the diagnostic evaluation should be guided not by the volume of hemoptysis alone, but by the actual presence. And with massive hemoptysis, we should do bronchial arteriography because it's preferable to MDCT. So in summary, hemoptysis is a symptom. It's very often the cause in the small or large airways, and MDCT is crucial in assessing the cause, the source, and the complications of hemoptysis. MDCT protocol should be carefully selected and the workup should follow the ACR appropriateness criteria. Thank you very much.
Do we have any questions from the audience for any of the speakers? Sort of hard to see with the lights out there. Diane, do we have any no virtual questions? All right. Going once, twice. God, we'll be up here for a few minutes if you have individual questions. Thank you.